I'm Dr. Fakir Rabari, and this is Superiority Clinical Trials. Well, there are many study types out there, such as randomized controlled trials and cohort studies. First and foremost, they vary from each other in quality. The focus of this topic is clinical trials, which are also referred to as controlled trials. Keep in mind that clinical trials can be randomized controlled trials, or they can be non-randomized controlled trials. Please take a moment to review these definitions before you move on to the next slide. Let's review the quality of evidence pyramid. At the bottom of the pyramid, you can see that we have the lowest quality of evidence. And these are data from animal data, simulation study, and expert opinion. Sometimes in the absence of higher quality evidence, these studies can actually be useful. Now, higher in the pyramid, we have case reports and case series, and these are descriptive studies. Slightly higher quality than this, we have case control studies and cohort studies, which are observational studies. And then we have very high quality evidence from controlled trials. So we have non-randomized controlled trials and randomized controlled trials, and these are extremely important because these are experimental studies, and I'll mention why this is very important. And of course, at the top of the pyramid, we have systematic reviews and meta-analysis, which we will discuss on a later day. The reason clinical trials are very important because they are the gold standard for drug approval. Of course, before a drug can come to the market, there will be a preclinical phase where the drug is studied first in a lab and then later studied in animals. And once a drug is discovered, it will make its way into clinical trials, and the clinical trials can have phase 1, 2, 3, and 4. Phase 1 clinical trials includes patients who are actually healthy volunteers, so it's a very small study, and they test the drug in healthy volunteers just to make sure that it's safe. Once it's proven to be safe, then they enroll in a phase 2 study patients who are actually have the disease, and this is the time where the investigators will actually try different doses to figure out the right dose that will be safe and effective. Once the dose has been determined from a phase 2 study, and once it's determined that it's safe and effective, then they will enroll a larger study from patients who actually have the disease, and they will study the drug to make sure that it's safe and effective. And of course, once the drug is approved after completion of phase 3 studies, there will be post-marketing studies at phase 4. Now, there are some exceptions to this. For example, antibiotics can actually be approved after completion of phase 2 studies, with the condition that they will have to continue to do a phase 3 study and submit the data to the FDA. Let's take a look at randomized clinical trials. There are 3 general designs of RCTs. The first one is a superiority trial. The point of superiority trial is to show the treatment in intervention group is more effective or superior compared to control group. This design is used for establishing new standard of care, meaning that in the absence of standard of care, it's ethical to give a control group a placebo. In situations where we have good standard of care, it might be unethical to give the intervention group a treatment that is not standard of care. The second design is non-inferiority trials. This design is to show that the treatment is not worse compared to control group. It is used for establishing alternative care. In other words, it's used when we have a drug that's not necessarily superior to the standard of care, but it might be another alternative. So we will use a non-inferiority design for that. And the last design is equivalence, which is used to show the treatment is not more effective and is not worse compared to control group. This design is used for establishing generic drugs that are equivalent to their brand formulation. Now, for superiority studies, the primary objective is to determine the magnitude of increased benefit of the experimental intervention over standard therapy for effectiveness outcomes. The first learning objective is identify different types of bias and random error encountered in clinical research. It is almost impossible to have an absolutely perfect clinical trial to find the absolute truth in the clinical study. There will almost always be some sort of error in the results of clinical trials. An error is basically deviation from the truth. Now, this deviation from the truth could be a random error due to chance, or it could be a systematic error which we refer to as bias. Now, the goal is to minimize these errors as much as possible so that the results will be as close as possible to the truth. Now, here's a list of some common types of bias that you will encounter. There are other types of bias as well, but these are some of the common ones. Please take a moment to review these definitions before you move on to the next slide. Let's take a look at an example. Let's say that we want to measure somebody's diastolic blood pressure. Blood pressure is routinely measured using either sphygmomanometer or an automated machine. Let's say that we use a sphygmomanometer to measure somebody's diastolic blood pressure and it happens to be 90. Now, if we use the same sphygmomanometer to repeat this measurement, it's possible to get some variation. So if we do it again, we might get 90 again, or it might be 89 or 88. So you get some variation. So even though you're using the same sphygmomanometer, you will get some variation, and these are due to chance. These are error due to chance. Now, let's say we were able to measure the true blood pressure using intra-arterial cannula, and this happens to be 80. Now, this deviation from 80, so if the average of these measurements using sphygmomanometer was 90, this deviation from the truth is due to bias. So in clinical trials, while there's little that can be done to prevent error due to chance, we want to make sure that we take measures to reduce the amount of bias. We identified different types of bias and random error encountered in clinical research. Now let's differentiate between intention to treat and per protocol analysis. When clinical trials report dropouts, they are typically due to two reasons: either non-adherence, for example, the patient is no longer taking the intervention, or lost to follow-up. For example, either the patient moved away or something happened to the patient so we couldn't follow up with them. The intention to treat principle essentially says that in the final analysis of the study, you have to count every patient who was randomized regardless of whether they received the intended intervention. Many experts argue that a more suitable term for intention to treat is as randomized. The per protocol principle, on the other hand, states that the patients have to follow the protocol in order to be counted in the final analysis of the study. Any violation of the protocol will exclude the patient from the final results of the study. Now, from intuition, you might think that per protocol is the way to go, because if you want to know if a drug really works or not, you want them to follow the protocol. But this is dangerous. Removing patients after randomization can increase the risk of selection bias, which is what randomization is actually intended to prevent. In general, it is best to have intention to treat analysis. It is more representative of the real world. For example, patients are likely to miss doses here and there. So if we show benefit from intention to treat analysis, we will be more confident that the result will also be true in the real world where patients are likely to violate protocol. Now, there are situations where per protocol is preferred. For example, if you are trying to evaluate toxicity to show the adverse effects of a drug, if somebody didn't take their drug and the rate of adverse effects were low, that's not good. Let's take a look at an example. Let's say we conduct a study and we enroll patients with cerebrovascular disease. So these are patients who are at risk of having a stroke. Now, we randomize patients to two groups. One group will be the control group. We're going to give these patients in this group aspirin to see how effective aspirin is to prevent stroke. And in the intervention group, we will give aspirin, but we will also do surgery on these patients to prevent stroke. So as the study continues, we will measure how many patients will have stroke. So let's say that in each group, 10 patients will have early stroke and 10 patients will have late stroke, so later in the study. in both groups we will have the same amount of strokes. And in each group we have about 100 patients. Now, after randomization in the group that received surgery, it takes some time to prepare the patients for surgery. So the surgery is not done exactly at the beginning, so it takes some time to do the surgery. So these patients who had early stroke, they actually had not received the surgery. Now, by the end of this study, you can see that in the intervention group, 20 out of 100 had stroke, so 20% of them. And in the control group, also 20 out of 100 had stroke, so 20%. If you calculate the relative risk, 0.2 divided by 0.2 is 1. And relative risk reduction is 1 minus 1 equals 0. So essentially there is no difference between the control group and the intervention group. And this is the intention to treat analysis because we included all patients who were randomized. Now let's say we also want to do per protocol analysis. The protocol says that the patients had to receive surgery in order to be included in the study. Now you can see that 10 of these patients in the surgical arm actually had stroke before they had surgery. So after they had stroke, they were no longer a candidate for surgery. So if you do the per protocol analysis, you can say that if you exclude these 10 patients because they didn't receive surgery, you only have 90 patients in the study now. And of these 90, 10 of them had stroke. So the stroke rate in the intervention group was actually 11%. And of course, nothing changed in the control group because everybody received aspirin, so it's still 20%. Now, if you do the relative risk, so 0.11 divided by 0.2 is 0.55. And relative risk reduction is 1 minus 0.55, which is 0.45. Now, you can see that this shows a huge benefit of surgical intervention if you do the per protocol analysis compared to no difference when you do intention to treat, which is a huge deviation from the truth, which is essentially no difference between these two groups. So this is why it's important to consider intention to treat in randomized clinical trials. We identify different types of bias and random error in clinical research. We differentiated between intention to treat and per protocol analysis. Now, given a superiority clinical trial, evaluate its internal validity. When we evaluate the internal validity, we're basically evaluating how serious was the risk of bias. Now, here's a methodology from JAMA Evidence. JAMA is the Journal of American Medical Association, and they have formulated a systematic way to appraise a randomized clinical trial. Now, in order to minimize the risk of bias, we want to make sure that the groups that we are comparing have the same prognosis. We want to make sure that they have the same prognosis at the beginning of the study, during the study, and after the completion of the study. So the first question to ask is, did intervention and control groups start with the same prognosis? Now, this is a general question, so the next three questions are actually more specific in order to answer that question. Now, one of the best ways to make sure that the two groups are similar are by the process of randomization. However, randomization alone is not enough. So the next question to ask is, was randomization concealed? Now, keep in mind that this is referring to concealing of the randomization process itself. It's not referring to the blinding system or the blinding of the study. Now, by concealing the randomization process, we just make sure that people who are responsible for recruitment do not systematically enroll sicker patients to either a treatment or control group, because then the patients will not have the same prognosis in both groups. The next question to ask is, were patients in the study group similar with respect to non-prognostic factors? This is where we actually evaluate the baseline characteristics, which is usually provided in table 1, sometimes in table 2, but it's important to look at those baseline characteristics. Now, usually in the smaller studies, you're more likely to encounter groups that do not have balanced baseline characteristics. The larger study, the more likely that the two groups will be similar in regards to baseline characteristics. Occasionally, when randomization process doesn't result in similar groups as far as baseline characteristics, there are statistical techniques that can be applied and adjust for those imbalances. Now, as the study progresses, it's important that the two groups continue to remain similar as far as prognostic fact. And that's where blinding comes into play. It's important to have blinding or masking of the study in order to maintain prognostic balance. So studies that are open label basically do not have any blinding. Now some studies could be single blind or it could be double blind, where both investigator and participants will be blinded. Please take a moment to review these definitions before you move on to the next slide. And finally, we want to make sure that the groups are prognostically balanced at the study's completion. It's important to evaluate how many patients were lost to follow-up because that could compromise the study, and I'll show you an example on the next slide. The real concern is, are patients lost to follow-up because they died and we don't know about it? Or is it because they are doing really well and they're not following up because they actually cured their disease and they moved on with their life? We also want to evaluate if a study was stopped early, because that could lead to overestimating the treatment effect. Now imagine we have two trials. Both trials have a treatment group and a control group with 1,000 patients in each, and they had the same number of lost to follow-up. So let's say 30 patients in each group were lost to follow-up. Now the primary endpoint in these two studies, let's imagine, is mortality. In trial A, a lot of people died. So 200 people in the treatment group died and 400 people in the control group died, leading to a 50% relative risk ratio. Now compare that to trial B, where it had the same number of lost to follow-up, but the number of deaths were actually much smaller. So only 30 patients died in the treatment group and 60 patients died in the control group, resulting to a 50% relative risk reduction. Now, the question is, what happened to the people who were lost to follow-up? In order to do sensitivity analysis, we can actually consider the worst case scenario, meaning that we can actually consider those 30 patients to have died. We assume the worst case scenario, so the reason they haven't come back to follow up is because they died. So if we actually add these to the number of deaths, when the number of deaths are very high, it actually makes minimal difference. So when you add those numbers, you actually get the relative risk reduction of 43%, which is similar to 50. Now in the study B, where the number of deaths was very small, when we add those numbers of the lost to follow up, you actually double the number of deaths. So that's gonna have a huge impact on the results when we do the sensitivity analysis. That's why it's important to consider the number of patients who were lost to follow up when evaluating clinical trials. And lastly, we want to make sure that the patients were actually analyzed in the groups to which they were randomized. This is where the concept of intention to treat comes in, where any patient who actually was assigned to the medication will be included in the analysis regardless of whether they took the medication or not. Here are ways to reduce the risk of bias in clinical trials. So that at the start of the study, we want the groups to be similar. So we do randomization with stratification. And then as the study proceeds, we want to use blinding of the patient, of caregivers, assessors of the outcomes. And then at the completion, we want to ensure complete follow-up, completing study as initially planned by sample size calculation, and including all patients whom data are available in the arm to which they were randomized. And here's a summary of the beneficial effects of these techniques. So for example, randomization will ensure prognostic balance between the groups at baseline, reduces selection bias, reduces confounding bias. Blinding maintains prognostic balance between the groups, reduces placebo effect, reduces co-intervention, reduces bias in assessment of outcomes, and so forth. We looked at different types of bias, random error, and we differentiated between intention to treat and per protocol analysis. We also evaluated the internal validity of superiority clinical trials. Now, let's differentiate between primary, secondary, clinical, and surrogate endpoints used in clinical studies. As we have learned before, clinical endpoints are patient-important outcomes such as stroke, MI, pain, health-related quality of life, and mortality. There are also surrogate endpoints or markers that are actually substitutes for those clinical endpoints. Some examples include A1C, blood pressure, and degree of atherosclerosis. Although clinical endpoints are preferred to surrogate endpoints, substituting surrogate endpoints for clinical actually permits researchers to conduct smaller and shorter trials. Now, regardless of whether endpoints are clinical or surrogate, they can be either primary or secondary. Primary endpoints are actually what the study is designed for. And the reason this is important is because the design of the study is supposed to reduce any bias towards measuring that primary endpoint. And that's a difficult task, to reduce the risk of bias. Now, because it is expensive to do studies, there are also other endpoints that we will look at in the study, and they are referred to as secondary endpoints. So although they are looked at, because the study is not designed to measure the secondary endpoints, there's actually risk of bias when measuring these outcomes. So what that really means is that if the study finds something for a secondary endpoint, it's a hypothesis generating. So they should do another study to actually investigate what they found for a secondary endpoint, and in the new study they will actually make that the primary endpoint. Now, a lot of the times you will see the primary endpoint as a composite endpoint, meaning that there will be multiple endpoints bundled together in one single primary endpoint. And the reason for this is that sometimes it will take a very, very long time to get the number of events for a single outcome, and sometimes it becomes unrealistic to actually conduct a study. So by bundling multiple things in one primary outcome, it becomes easier to conduct a study. Although it makes it easy, but it also makes it more difficult to interpret. So it's extremely important to figure out which one of the components is actually giving the benefit. We identified different types of bias and random error, and we differentiated between intention to treat and per protocol analysis. We evaluated the internal validity of superiority clinical trials, and we differentiated between primary, secondary, clinical, and surrogate endpoints used in clinical studies. Now, let's interpret clinical and surrogate endpoints used in superiority clinical trials. Clinical trials can have various number of groups or arms. For example, a single arm study will include a single group of patients, whereas a double arm study will evaluate two groups of patients, which is most common. So majority of clinical trials have two arms in their study. Some studies can also have multiple arms of patients. Now, ideally, you would like to have a control group in this study. And now in this control group, it can either be placebo controlled or it could be active control study. In a placebo control group, this typically happens when the disease that we're evaluating doesn't have a standard of care. So it is ethical for one group to receive placebo instead of treatment. And then in the other group, we give an active treatment. And some studies will actually use an active drug as a control. This is where some disease states already have a standard of care established, where it would be unethical to give placebo to those patients. So the control group will receive an active drug, and then the other group will receive another drug that the evaluators are trying to bring to the market, which we actually refer to as intervention group. So the other group is actually the drug that we want to study and evaluate to compare it to our control. So obviously the double arm study is the most common one. So the two arms, one of them would be the control group and the other one would be intervention group. When you have multiple arm studies, one of them will be the control group, and then you can compare the control group to multiple interventions. So imagine a 4-arm study where one of them is the control and 3 of them are intervention. So you can compare different drugs to the standard of care, for example. Now, occasionally when you have a single arm study, so that single arm would be your intervention group, and you would wonder, so how can you have a control group? And that's when you would use a historical control. So that would be a theoretical control group where investigator will use historical data from the past. This typically happens when the standard of care is not very good, so they don't really want to have patients enroll to receive the standard of care, typically due to low effectiveness or severe adverse effects. Now, as we have learned before, when you compare two groups in a study, there are two ways to look at it. You can either look at a risk difference, or you can look at a risk ratio. So let's take a look at risk difference first. So a study, depending on the number of the outcomes in either the intervention group or the control group, you can either have absolute risk reduction if the number of events are lower in your intervention group, or you can have an absolute risk increase if the number of events are higher in the intervention group, or there can be no difference between the groups. And the reason we are looking at 0 here is because we're looking at the absolute difference between the two groups, meaning that we're subtracting the number of events between the two groups. Now contrast that to the ratio. In a ratio, you're actually dividing the number of events in each group. So you can either have relative risk reduction or relative risk increase, or no difference between the groups. And now, because we're looking at the ratio, we're looking at 1 as no difference. Now, while risk difference and risk ratio are relatively easy to calculate, it's not easy to calculate hazard ratio, and that's because hazard ratio also takes into account the time to event. This analysis is referred to as survival analysis, and one way to visually show these analyses is using Kaplan-Meier curves.
So let's say your clinical trial is looking at patient's blood pressure. So let's say you find somebody's blood pressure and it goes here, and then you do it again and it's something here, and you do it again and it goes here, and you do it again and it goes here, and you do it again and it goes here, you do it again, it goes here, do it again, it goes here. So if you keep repeating your measurements for blood pressure, you start to get a distribution. So that's what we mean by distribution. So occasionally you have outliers that are far from the center of tendency for this, but like at the end of it, what you get is that you get the mean. So there's a mean for the distribution, and then away from the mean you have your standard deviation. So a standard deviation, so you can see this is one standard deviation, plus or minus, and then you have 2 standard deviations plus or minus away from the mean of your distribution, and up to 3, right? And then you can see that so 1 standard deviation away from your mean captures 68% of the distribution. So this right here is 68% of the distribution. Versus if you do 2 standard deviations from your mean, so plus minus 2 will capture 95% of the distribution. So that's a significant number because we are interested in 95% of the distribution, and we think that's clinically significant because that's within 2 standard deviation that captures 95%. So anything that's outside of the 2 standard deviation, it could be considered outlier. So that could be like a chance finding. And I'll explain that in a little more detail. But the reason, so one specific thing about normal distribution is that because it's symmetric, so your mean, median, and mode will be on the same line. So that's your center of tendency for the distribution. Whereas things that are not normally distributed, you can see that mean, median, and mode do not lie on the same line. So you can see this either negatively skewed or positively skewed as the data tend to go to left or right. So when it comes to interpreting superiority randomized clinical trials, you will hear the concept of two-sided significance level. So as I mentioned, we're interested in 95% of the distribution. So 95% is within 2 standard deviations from the mean. So here's our center of tendency, and we're interested in 95%. It's common to see a 95% confidence interval, and the way you calculate confidence interval is that it's equals to 1 minus alpha, and alpha is your significance level. So if you remember, when you interpret p-values, you need to know your alpha, because a p-value is significant if it's less than your alpha. And what we typically do in in randomized clinical trials is that we commonly use a 5% alpha or an alpha of 0.05, and that's why 1 minus 0.05 equals 0.95 or 95%. So anytime you have a alpha of 5%, you need to have a confidence interval of 95%, so that it follows this rule for confidence interval. So what this means is that obviously mu is the center of tendency or the mean of your distribution. So anytime you do an experiment, what you find in that study is your mean. And if you were to do that study again, chances are that you will not find the exact same thing. So if you do it again, it might be something different. And what we really mean here is that if you do the study again, we are 95% confident that it will be something between within 2 standard deviation. So anything outside of that might be considered a chance finding. And that's why if you remember the concept of type 1 error, so type 1 error means like a false positive. It can either be on this side or this side, and that's what we mean by two-sided. So it's a matter of whether it deviates from your finding to the right or to the left. So we allow 2.5% type 1 error on this side and a 2.5% error on this side, and together we call this a two-sided or two-tailed. You may hear the concept two-tailed and two-sided. It means the same thing. Two-tailed significance level of 5%. And superiority randomized control trials will always use a two-tailed significance level. Now, just to give you another example of this equation, so if someone was to use a alpha of 2%, so if they use the two-sided alpha of 2%, then they will have to use a 98% confidence interval. Because if you use a 95% confidence interval with an alpha of 2%, then that's a violation of this equation. So if you catch that in a randomized clinical trial, that should be a criticism of that study.
Let's take a look at some examples. So this is the charisma trial, where the intervention was clopidogrel plus aspirin, and the control group was placebo plus aspirin. And the primary endpoint was a composite of myocardial infarction, stroke, or death from cardiovascular causes. And this is in patients who had stroke. Now, this is a superiority study, so it's really trying to show if clopidogrel is superior to placebo. Now, when you look at the results, you can see that the p-value is 0.22, meaning that there's no statistically significant difference. However, let's interpret the confidence interval. So you can see that in the study, they found the relative risk of 0.93. So that's what we found here. So that's the point estimate. 0.93 is what they found in the charisma study. The question is, if we do this study again, what are they going to find? And they said that it could be something between 0.83 to 1.05. And now, because this is a superiority trial, we do not want the confidence interval to cross the line of unity or line of no difference. In this case, it crossed the line. So 1 is included within the confidence interval, so it is not statistically significant. Now, note that this p-value is for superiority and is in agreement with the confidence interval. Let's take a look at another example, the sprint trial. This study looked at patients with hypertension, and it was comparing intensive treatment to standard treatment. And the primary endpoint was a composite outcome of myocardial infarction, other acute coronary syndromes, stroke, heart failure, or death from cardiovascular causes. As you can see, now the p-value is statistically significant. Again, this is a superiority trial, and you can see that in this study they found a hazard ratio of 0.75, so this is the point estimate. The question is, if we repeat the study, what are we going to find? And they say that it will be something between 0.64 and 0.89. And in this study, it actually, the confidence interval does not include the line of unity. So that's why in this case, we can conclude that the intervention group is superior to control group. Note that in the previous example, we did not calculate absolute risk and number needed to treat because the results were not statistically significant. In this case, because the results are statistically significant, we can actually calculate absolute risk ratio, absolute risk reduction and number needed to treat. And also note that this p-value is for superiority. So we can say this group is superior to the control group. Now let's look at the ILLUMINATE trial. In this study, the primary endpoint was the time to the first major cardiovascular event, which was defined as death from coronary heart disease, non-fatal MI, stroke, or hospitalization for unstable angina. As you can see, they found the p-value is statistically significant and the hazard ratio is 1.25. So 1.25 is the point estimate. The question is, if we repeat this study, what are they going to find? And they said that it will be something between 1.09 to 1.44. So as you can see, the confidence interval does not include 1. So the results are statistically significant. However, it's on the right side of 1. So it's actually in favor of the control group. So the intervention is actually inferior to the control group, or you can claim that the control group is superior to the intervention. Again, this p-value is for superiority. Now let's look at the CANTATA-SU trial, which is again a superiority trial. Now this one has a surrogate endpoint of change in weight. So they're looking at the two groups, and you can see that they found the difference in weight to be a negative 4.4 kilos, which is the point estimate in this study. Now the results are statistically significant based on the p-value, and the confidence interval goes from negative 4.8 to negative 3.9, which does not cross the line of no difference, line of unity, which is 0 since we're looking at an absolute difference. Now, even though the results are statistically significant, we're not calculating number needed to treat because this is a surrogate endpoint. So this is the syntax trial that looked at PCI versus CABG. So PCI is the intervention group and CABG is the control group. And the primary endpoint was the composite endpoint of death, MI, stroke, and revascularization. So as you can see, 17.8% of patients in the PCI group had either death, MI, stroke, or revascularization, whereas in the CABG group, 12.4% had the primary outcome. And the results are statistically significant, as you can see the p-value. And when you look at the risk difference is a positive number. So it's positive 5.4. And because it's positive, it means an absolute risk increase. So you can see more people had the events in the PCI intervention group. So it was actually a risk increase. You can also analyze it by looking at the relative risk. So relative risk is 1.44. So because it's greater than 1, that means there were more events in the intervention group. So if we call the PCI group Group A and the CABG group Group B, then the actual risk difference would be A minus B, which is 17.8 minus 12.4, which is positive 5.4. So because this is greater than 0, this is an absolute risk increase. And the results are statistically significant. When you look at the relative risk, you're looking at the ratio. So it's the ratio of A to B. So because you have 17.8 divided by 12.4, you get 1.44, which is greater than 1. And that's how you know this is a relative risk increase. So when you look at the risk difference, because if you subtract the same number, you get 0. You don't want this confidence interval to cross 0, and it didn't. So it goes from positive 2.13 to positive 8.83. So it did not cross 0. Also, if you look at the relative risk, because the same number divided by itself would be 1, and 1 would be no difference, you don't want the confidence interval to cross 1. So, and it didn't. It's from 1.15 to 1.81. So it's statistically significant, and the p-value is consistent with it. Now, the problem is, if you were to tell someone about the results of this, they may be wondering, well, if I get the, looks like CABG had less events, so if someone was to get CABG, are they less likely to die? And that's hard to tell from a composite endpoint. That's why it's important to look at the individual components of the composite endpoint. So when you look at deaths, you can see that it's actually there's no statistically significant difference between the two groups. So it really doesn't make any difference on the mortality outcome. Now, when you look at stroke, you can actually see that the stroke is in favor of the PCI group. So if people were to get PCI, they're less likely to have stroke, because as you can see, 0.6%, less than 1% of patients had stroke in the PCI group, and 2.2% had stroke in the CABG group. So now you can see the relative, or I should say the risk difference is a negative number. So now you're looking at an absolute risk decrease in favor of the PCI group, and it's statistically significant. Look at the p-value, and it didn't cross 0. So it's all of it is in the negative side. The same is true with the relative risk. You can see that it's less than 1 and it didn't cross 1. So now for the stroke, it's actually in favor of the PCI group, even though the composite endpoint doesn't say that. Now you look at MI, you can also see there was no difference. And then when you look at the subsequent revascularization, you can see that a lot fewer people had revascularization in the CABG group. So that's actually, it's revascularization that's driving the composite endpoint. So although when you bundle all of them together, it looks like it's in favor of CABG, but it's really the revascularization that's driving it. So if someone didn't want to have stroke, it's actually to their benefit to get the PCI intervention. We looked at different types of bias and random error and intention to treat and per protocol analysis. We evaluated internal validity of superiority clinical trials, and we interpreted clinical surrogate endpoints used in superiority clinical trials. Now, given a superiority clinical trial, evaluate its external validity. Once we interpret the results of randomized clinical trials, we need to clinically appraise the results before we can decide if the results actually apply to our patients. Of course, the first question we ask is, were the results statistically significant? And for this, we often look at the confidence interval along with the p-value. And if the p-value is less than alpha, and in clinical trials we typically set alpha at 5%, we conclude that the results are statistically significant. And the reason we typically set alpha at 5% is that we don't want more than 5% chance of having a type 1 error. So we minimize the risk of having a type 1 error. Now, if the p-value is greater than alpha, the results are not statistically significant, which could actually be due to a false negative or a type 2 error. Now, in order to evaluate type 2 error, we need to know the power of the study. So anytime the results are not statistically significant, you should always look at the power to see if the study was actually powered to find a difference before you conclude that there is no difference between the groups. When it comes to power, we look at beta, and beta is typically set between 10 to 20%. Usually, it could be a different number, but usually we are good with about 10 to 20%, which will result in a power of 80 to 90%. So we use this equation, power equals 1 minus beta. And the reason we are interested in power is that we use power to actually calculate sample size. So for example, in order to have an 80% power, you can actually calculate to see how many patients are needed in the study in order to have that power. Or sometimes instead of number of patients, they look at the number of events. So how many events, for example, how many number of mortalities need to happen in the study in order to be able to find the difference between the two studies. So when you look at those calculations in a study, so let's say the study says we need to have 2,000 patients in the study to have 80% power, but they only included 1,000 patients, that means that study was underpowered. So if the results are not statistically significant and the study was underpowered, you can conclude that this is due to a false negative. So they need to follow up with other studies with larger sample size. Now, sometimes when the results are statistically significant, it could be due to overpower. So sometimes if you have too many patients or too many events, you can actually find a statistically significant difference between the two groups, but it might actually be smaller than the smallest effect of clinical interest. For example, let's say that you conduct a study to compare two drugs and you're interested to find a reduction of risk of mortality of at least 10%. Now, if you do find the results to be statistically significant, but the drug only reduced mortality by 2%, that really didn't reach the minimum 10% that was of interest. That could often be due to being overpowered. The next questions to consider are, how large was the treatment effect? So when you look at the size of the treatment effect, you can look at things like absolute risk reduction or relative risk reduction. And you can also calculate number needed to treat or number needed to harm. Next, you should look at how precise was the estimate of the treatment effect. This is where you should pay very close attention to the confidence interval. So the size of the confidence interval will tell you how precise was the results of the study. So the results of the study are referred to as a point estimate, and the confidence interval is important to know if you were to repeat the study, how likely is it to have something close to the point estimate. So for example, let's look at two studies. Studies A, which is shown in orange, and study B, which is shown in green. So although both of them have the same point estimate, both studies showed a relative risk reduction of 25%. But when you look at the confidence interval, you can see that study A had a very wide confidence interval, whereas study B had a narrow confidence interval. So we can say that study A is less precise compared to study B, or study B is more precise because the confidence interval is narrower. It's also important to consider the confidence interval when we want to make clinical significance out of the results. So you can say, although the point estimate was 25% relative risk reduction, the effect could be as low as 9% or as high as 41%. So if you were to make a decision for your patient, you should consider, like, is 9 a significant number? Or is 41 a significant number? If the answer to both is yes, then the point estimate is clinically significant. Whereas if if the answer is one of the ends of the confidence interval is no, so negative 38 is not a good number for your patient, then you can say that this is not clinically significant, because although 25 is a good number, the true effect could actually be negative 38. So it's important to consider the confidence interval when you want to make clinical sense out of the results. And now the actual external validity of the results. So the external validity is basically looking at the generalizability of the results. So how can I apply the results to patient care or to my patient? So what you really want to do is to see how similar were the patients in the study to your patients. So this is where you examine the inclusion and exclusion criteria in the study. And also you look at the average patient in the study. You look at the baseline characteristics. So what was the average age? What was the gender? Where did they come from? What comorbidity did they have? What other medications are they taking? And it's not that it has to exactly match your patient, but you really look for compelling indications that to look for things that would indicate that the results don't apply to your patient. So if you cannot find compelling indications that the results do not apply to your patient, then you can say that this study is generalizable and apply to my patient. Next, you should evaluate to see if the study had patient important outcomes. We already discussed surrogate endpoints versus clinical outcomes, so you should see if the outcomes are actually important to your patient, and that could depend on the actual disease that your patient has, and things like comorbidities and patient-specific factors. And of course, when it comes to composite endpoints, you should also evaluate which component of the composite endpoint actually applies to your patient and if it's significant. Now, as you have learned before, it's extremely important to calculate number needed to treat when you analyze the results of these studies. So in order to calculate number needed to treat, the results need to be statistically significant, the endpoint needs to be clinical, and it must be a superiority trial. So do not calculate number needed to treat for surrogate markers, do not calculate it if the results are not statistically significant, and do not calculate it in non-inferiority studies. Now, the calculation is relatively simple. It's basically 100 divided by absolute risk reduction, as long as you're calculating absolute risk reduction in percentage. Here are some examples. Imagine we are looking at the percentage of patients who died in each group. So if 1% of patients died in the intervention group and 2% died in the control group, the relative risk would be 0.5. So 1 divided by 2, 1% divided by 2% will give you 0.5. So relative risk reduction is 50%, and the absolute risk reduction is 1. So 2% minus 1% is 1%. So the number needed to treat would be 100 divided by 1, which is 100. Now, what if 20% of intervention group patients died and 40% in the control group died? You can see the relative risk is still 0.5 because 20% divided by 40% is 0.5. So because it's 0.5, you still have 50% relative risk ratio. But the absolute risk reduction is a huge number now. So 40% minus 20% gives you 20%. So 100 divided by 20 is 5. So as you can see, it's much more useful to look at absolute risk reduction and number needed to treat when you analyze the results, because relative risk ratio can be misleading. As you can see in these two examples, relative risk and relative risk reduction, they were the same numbers, but you can see that the actual benefit is much larger in the second group. Now let's also look at this one. So if 30% died in the intervention group and 40% in the control group, 0.3 divided by 0.4 is 0.75. So 1 minus 0.75 is 0.25. So you had 25% relative risk reduction. The absolute risk reduction is 40 minus 30%, so it's 10%, and 100 divided by 10% is 10. So number needed to treat is 10. And that means that you would have to treat 10 patients with whatever they received in the intervention group in order to avoid one death, as compared to the patients who received the control treatment over the period of time of the study. Now, these are just hypothetical numbers just to show you how to calculate. And lastly, are the likely treatment benefits worth the potential harm and cost? And this is where we want to see if the results are clinically significant. So you can look at things like cost, and you can also look at number needed to treat and number needed to harm to balance the risk versus benefit. Now, it's not to say that number needed to treat and number needed to harm are equivalent when you compare the numbers. So for example, if the number needed to treat is 50 and number needed to harm is 40, you cannot just say that, well, the harm is more than the benefit. So you have to see, you have to use these numbers in context. So for example, if number needed to treat of 50 is for mortality and then number needed to harm of 40 is just for a headache, it's okay if you're causing more headache, in favor of saving a life. So you gotta use these numbers in context, and these are just tools to help you making a clinical decision. Of course, the values and preferences of patients must also be considered and respected. So in summary, we looked at internal and external validity of studies. So in general, let's say this represents the population, and your patient is among this population, and obviously we cannot study the entire population. So what we do is we actually take a sample of the population. So this is the sampling. This is where we have the inclusion and exclusion criteria to get a sample from the population and put it in our study. And then the internal validity looks at the risk of bias in when we measure the outcomes. So, for example, there could be selection bias and so forth. And then once the study is concluded, you will have a conclusion, when you compare the two groups. And then once, assuming the study had good internal validity and the results are valid, meaning that there was, reduced risk of bias, so the conclusion, the results are close to the truth, then the question is, so definitely the results applies to the sample from the population because those were the people that studied. The question is, how generalizable is it? Does it apply to the rest of the population? And more importantly, does it apply to your patient? And that's where external validity comes in, and you need to evaluate, things like inclusion, exclusion criteria and patient characteristics to see if that's close to your patient. And then also to balance the risk versus benefit, the cost, and also the patient values and preferences before you make a decision. This concludes this presentation.